my name is Tess Taylor, and I'm a specialist in community education at MDA. We're thrilled to have you join us for today's live Q&A for LGMD Awareness Day on September 30th. This learning event is part of our larger MDA Community Education program, which focuses on bringing the neuromuscular disease community together around education and resources. For those attending live, we encourage you to submit questions in the chat, and we will ask our panelists your questions live, so please get those questions ready. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to the care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, advocacy, access to care, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. At MDA Care Centers, located at over 150 top medical institutions nationwide, people living with neuromuscular disease and their families find more than medical expertise. They experience a community fiercely dedicated to advancing access to care and nurturing hope. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, treatments, independent living, newborn screening, and more. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. If you haven't done so already, we invite you to join the MDA community by registering with us for free at mda.org. Now it's my pleasure to introduce today's speakers. Peter B. Kang, MD, is a pediatric neuromuscular neurologist and physician scientist. He is the director of the Greg Marzoff Jr. Muscular Dystrophy Center at the University of Minnesota, where he also serves as professor and vice chair of research for the Department of Neurology. Dr. Kang is the presenter of the recent Updates in Research and Care for LGMD webinar and will be answering questions related to these topics today. Kamdar, MD, is a cardiologist who treats advanced heart failure. She practices primarily at M Health Fairview Clinics and Surgery Center Heart Care. Dr. Kamdar is the presenter of the recent Cardiac Care for LGMD webinar and will be answering questions related to cardiovascular health today. Molly Stark, DPT, is a physical therapist and clinical evaluator at the Greg Marzoff Jr. Muscular Dystrophy Center at the University of Minnesota. Dr. Stark is the presenter of the recent At-Home Physical Therapy for LGMD webinar and will be answering questions related to exercise and physical therapy for LGMD today. So thank you all so much for joining us. Again, we do have some questions that came in during our registration period, and so we'll be answering those in the chat alongside questions that you're submitting today. And I am not seeing. Can anyone let me know if they are able to hear me?
I can hear you, Tess.
Okay, great. I'm so sorry. I'm having some internet connection issues today, and I'm not able to see any of our presenters or panelists, but that's okay. So we'll just go ahead and I'm going to start answering the questions. And then as the chat comes in, we will check on the chat and answer those questions as well. So my first question will be for Dr. Kang today. Hi, Dr. Kang, and thank you so much for being here. We had quite a few questions regarding LGMD subtypes. I'm going to start with a couple questions for you regarding LGMD 2A. So one question we had were, are there any clinical trials being held for LGMD 2A? And is there any new research with stem cell treatment for LGMD 2A?
So, yeah, thank you very much for inviting me to this, and it's really wonderful to be here, and many thanks to the MDA. There is active research going on LGMD 2A, and including studies of gene therapy, stem cell therapy. For details about any specific studies, I do recommend that all of the participants go to this website called clinicaltrials.gov. It's a federal government website, and Any trial that is officially registered with the US government is posted there, and that provides a lot of authoritative information. It doesn't give you advice about which trials are advisable to enroll in. Those are discussions you should have with your family and with your physicians and your other care providers, as well as patient organizations who provide a lot of helpful information.
Great, thank you so much for that. My next question will be for Dr. Stark, for Molly. We had one question that came in during registration. Are there any online videos or creators you would recommend with exercises for a person in a manual wheelchair? I have LGMD and I use a manual wheelchair.
This is a good question. But first off, thank you for having me. I'm very grateful to be part of it. In terms of manual wheelchair exercises, I have not come across any that are specific to LGMD. If anybody has, feel free to share them in the chat. Sometimes the patient community knows more than the therapists do because you've searched long and hard for them. I know there is a great one produced by Working on Wellness that does exercises for people in manual chairs or power chairs. They're all seated exercises. They're really developed though for like MS, Parkinson's, and arthritis. So it's really not specific to limb girdle, but I think you can find some exercises that could work for you in that website. But of course, like not every exercise that they're going to list is appropriate for limb girdle or for you in particular. So certainly talk to a PT before you start doing them. One other resources is there's a great channel on YouTube called Feeling Fit with FSHD. Again, not limb girdle, but they have some ideas that might work as well, and they have a lot of seated exercises. So check those out and talk to other patients who might have found something that I haven't found yet.
Great, thank you. I think that will be very helpful. So now, Dr. Kamdar, a question for you. Someone wrote in and said, I have LGMD and also cardiomyopathy. What is the best way to manage edema in the feet and legs when I find it difficult to take water pills regularly?
So first, thank you for having me here. Cardiovascular health and patients with living with neuromuscular disorders is a passion of mine, and what I do regularly in the clinic and in the lab. I think that's a really good question. How do we manage the heart disease associated with limb-girdle muscular dystrophy? So for this question with regards to the cardiomyopathy, when the heart muscle is weak, it's not able to pump as much blood, and therefore swelling in the legs, shortness of breath. These are some of the symptoms that can occur. I think one of the main things in terms of managing the fluid is to see your cardiologist regularly, and because we can actually look at how much fluid is on board within the blood vessels. And it's especially important with patients with who are living with neuromuscular disorders, because often if your legs are down, what we call dependent edema, where the fluid is building up in the legs, can be managed in different ways through elevating the legs, wearing compression stockings, and if necessary, if the fluid levels are high within the blood vessels, using diuretics. But there's many ways to manage that, and I think getting input from your cardiologist is the best way to go about it.
Absolutely, thank you. So let's go back to Dr. Kang. What is the long-term prognosis for someone with LGMD2A once they are wheelchair bound?
So it's variable, and this is true of all patients with limb-girdle muscular dystrophy, is that it is a big milestone, unfortunately, when loss of ambulation does occur, and it can happen at different ages. What I would say is that when you lose ambulation, you become at higher risk for certain other complications, including pulmonary complications and orthopedic complications, sometimes cardiac as well. And so the monitoring of your health needs to accelerate a little bit and be a little bit more intense. And I know that it's difficult to make it to more medical appointments, but that's to make sure that you stay as healthy as possible. And so in terms of long-term prognosis, a lot depends on whether there are cardiac and pulmonary complications and the timing of those and the severity. One thing that's very important is to keep your lungs as healthy as possible. And I think I saw in the chat that there were some people talking about the lungs, and it is important to get chest physiotherapy in the appropriate circumstances. Try to get vaccines that are appropriate to protect you against some of the causes of pulmonary complications, and just try to stay as active as possible. So what I would say is that it's hard to be very specific, because I've noticed that patients have very different courses, but I would say that if loss of ambulation occurs, you do become at higher risk of certain complications. And so the healthcare monitoring and potentially interventions do get a little bit more intense.
Thank you. So back to Dr. Stark. Are non-strengthening exercises better or less harmful in order to keep muscles stronger and do the most independently for longer? Let me go ahead and say that again. Are non-strengthening exercises better or less harmful in order to keep muscles stronger and be able to maintain independence in and physical independence longer? And do you know where anyone can find some data on this?
Yeah, this is a good question, because we kind of hear about, and I talked in my presentation about that some strengthening things can be detrimental to the muscles. And so really it's a balance about being active and then not pushing things too hard. So in terms of like picking and choosing your exercises, there's a variety of exercises that I talked about in the program. And some non-strengthening exercises are good, but some strengthening ones are also good to include. So it's really having a variety of exercises in the program. The main thing is that when you do strengthening exercises, to avoid some of those red flags that I talked about, like if there's any dark urine that you have or muscle soreness that lasts for more than 24 hours, that means that it was too intensive strengthening and you should scale back. There are a couple trials that have looked at strengthening exercises and also aerobic exercises. The first one was done back in 2007 by Speen and colleagues that they can look up online. That one showed that endurance training is safe and effective. It was 9 patients with LGMD2I who cycled for 30-minute sessions. They did well. Their CK didn't increase, and their strength stayed the same, and their endurance improved. And then a few years later in 2013, Speen's group did another one looking at strengthening with LGMD2I and 2A, and they found that resistance training was safe and effective in that group when done at low intensity. They did a high intensity and low intensity group. The high intensity group had some elevated CK. So in the presentation, I talk about what is too high, so you can look in there for that. Let's see, and then there's another one that was done more recently in 2021 by Turkin et al. And that one found that doing a balanced program with joint range of motion, strengthening, gait training, posture, breathing exercises, and relaxation exercises was beneficial, especially if the program was tailored to each patient's individual needs. So that's where working with a PT is really helpful, at least when you first get started, to make sure your program is developed with all of your individual needs in mind.
Great, thank you so much for that. So to Dr. Kamdar, we had a question come in at registration, and after this, I'm going to get to some of the questions that have been coming in the chat for our next round. But someone wrote in saying, I've been living with heart palpitations and dizziness for some time now, but all echo EKGs look okay. My heart MRI showed abnormal tissue, but function is okay. So what are the markers to watch for concerning our hearts with LGMD?
Thanks for that question. I think it's a great question because the heart muscle involvement in limb-girdle muscular dystrophy comes in 2 flavors. One is if you think about the heart like a house, there's the walls of the house, which is the heart muscle. The electrical system is the electrical and conduction part of the heart, and then there's the plumbing, and that's the arteries of the heart that provide blood to the heart. So the 2 main aspects that are affected by limb-girdle muscular dystrophy are the muscle, which can cause muscle weakness, and then the electrical system of the heart. And so with that, with the palpitations, when we do an ECG, that just captures a brief moment in time when the ECG is captured. And often patients don't have palpitations all the time. So one of the things that's recommended is to do a type of ambulatory telemetry monitoring. So it's Holter monitor, Zeo patch monitor, where you wear a little patch and your cardiologist can decide, depending on how frequently you're having palpitations, how long you might wear them. People can wear these up to 14 to 30 days. And that gives you a longer time. And if you have, for example, sensation of palpitations, you can actually click the monitor and it records when you have symptoms. So your cardiologist, when they read it, can correlate the symptoms along with when the rhythm happened. And so that's a good way to be able to identify if there is an abnormal rhythm that's occurring with limb-girdle muscular dystrophy.
Yeah. And then I finished my test.
Sorry about that. I think someone in who has audio access might not have their mute on. But thank you for that answer, Dr. Kamdar. So back to Dr. Kang, we had a question come in the chat, and also quite a few questions came in at registration about pain associated with LGMD. So I was hoping you could talk a little bit about that. We had one specific question: what can patients and caregivers do to address a lot of pain with LGMD? Are there any studies being conducted, and what kind of pain relief would you recommend to a patient who's experiencing a lot of pain with LGMD?
It is becoming increasingly recognized that pain is a significant issue with patients with LGMD. And I think it's multifactorial. Sometimes pain can come from the nerves. There are other times when they can come from orthopedic complications, and sometimes they actually come directly from the muscles. So a lot depends on what the exact cause is for a particular patient. So one of the things I do in clinic when a patient tells me that they're having some discomfort or pain is I try to figure out which of those it might be coming from. And sometimes we'll need to do diagnostic testing. And in particular, if it's really one spot and I'm concerned there might be a joint or something that's orthopedic, then either I'd order x-rays or refer to an orthopedic specialist or other specialist. So it is important if there's pain going on that you try to get to the bottom of it. Pain that's coming from the muscles themselves, there can be cramping issues, and especially with exercise that can happen. Sometimes pain is a signal coming from your body telling you that that you should take a rest. And so if it's a case where you're exercising and you're having pain, you probably should take a break. If it's pain that's coming without any exercise or other trigger that you can think of, there might be something else going on. So unfortunately, there's not a lot of published literature about pain in LGMD. I'm hoping that as time goes on, we can all study this a little bit better and try to dissect out how often it is that it's coming from bones or joints and how often it's coming from muscle and how much it's coming from nerve, and then what the different treatments can be. Sometimes if it's muscle related, I'm a little cautious about prescribing muscle relaxants because if you take too much, it could actually worsen your weakness. So I'm a little hesitant about muscle relaxants, but usually over-the-counter pain medications can be tried. It's always a good idea to check with your physician first, but in a lot of cases, unless there's something specific going on that is a problem, those should be okay. And sometimes massage can help, and sometimes redirecting exercise programs. If your exercise is a little bit higher impact, redirecting it towards a lower impact exercise program can help. So I think there's a lot we need to do to look into both causes and potential therapies for pain. But fortunately, I think it's good that there's more attention being drawn to it, and we'd like to figure it out better.
Yeah, absolutely. Thank you. So a question that came in for you, Molly, in the chat: is there a specific certification or designation for physical therapists that are qualified to work with people living with muscular dystrophy? If not, what are some good questions to ask of a general physical therapist to gauge whether or not they would be a good fit for me?
Yeah, this is a good question. Because LGMD is rare, sometimes PTs out in the community don't have experience with it, but they may be the only one that you have access to. So one, if you are able to kind of shop around for a therapist, is that some of them have a neuro designation where they've completed a fellowship in neuro, and oftentimes they'll have exposure to neuromuscular disease in general. It may not be LGMD, but potentially they've learned more about muscle disease. If the therapist doesn't have that, some questions to ask them are mainly just if they're willing to learn. Physical therapists are trained to treat people's impairments. So if they have strength loss or range of motion loss or pain, and so if they can kind of figure out what the impairments are, then they can treat those. And then on top of that, they do need to get a little background knowledge on how much exercise is appropriate, what kind of interventions are appropriate. So as long as they're willing to learn, I think they can find out kind of what they need with a good search online, or connecting with a therapist or a neurologist who does see people with LGMD and can point them in the right direction to some good articles that'll help them.
Great, thank you. So to Dr. Kamdar, we had a question come in. What should my cardiologist know in order to better understand my LGMD diagnosis?
So again, great question. So, like I mentioned, there's multiple different aspects that can be involved with the heart with regards to limb-girdle muscular dystrophy. Typically, it's the cardiac dysfunction, like heart failure, and then arrhythmia. So those are the two big types of things that we're looking out for. And given that there's so many different subtypes that are being better recognized now and being better distinguished, those patterns are being identified in different limb-girdle muscular dystrophies in terms of the cardiomyopathy or arrhythmia development. So I think cardiologists, Feingold et al. There's an American Heart Association guideline that was published in 2017. It's a great resources for cardiologists to be able to look at what are the different, gives a good overview of the different types of muscular dystrophies that patients are living with and what the possible cardiac involvement might be. And then there's also some guidelines in terms of what type of workup should be done. So, I typically recommend getting an ECG, some sort of ambulatory telemetry monitoring, and cardiac imaging, because that covers the major areas of the heart involvement in limb-girdle muscular dystrophy.
Great, thank you. So Dr. Kang, another question from the chat, and I will generalize this a little bit. Someone was asking pretty specific, but just in general, is there a possibility to participate in a gene therapy? This person was LGMD R9, but they are not living in the United States. So are you able to participate in gene therapy if you're not living in the US?
The sites for clinical trials vary a lot, and a lot of trials are held in the United States and are primarily for patients in the United States. But some trials, especially the ones that have larger enrollments, do have international sites. And then there are some gene therapy trials that are being hosted overseas. So even though the bulk of the work on gene therapy is done in the United States, it's by no means the exclusive country that has those. So the one thing I should note about that website, clinicaltrials.gov, is that it does also list international trials. So even if you live overseas, you could check it. It may not be as comprehensive for overseas trials, but it does have some of them listed.
Okay, thank you. So I think if anyone does have questions regarding gene therapy, it's probably a good idea. You can contact us at the Research Center at MDA, or you can go ahead and log into that website that Dr. Kang is discussing and speak directly with your care providers and your team to see if that's a possibility. So let's go back to Molly. We had a question come in. I heard Dr. Nicholas Johnson say that he saw evidence that LGMD progressed more quickly during COVID among those whose lives can be more sedentary, and that exercise is the single best thing to do to manage LGMD. So I know you're not an LGMD specific doctor, but can you talk about this at all?
Yeah, definitely. He's absolutely right. I think not even just in LGMD, but across the board through COVID, we saw a lot of people with neuromuscular disease showing more signs of progression during that time because they had a more sedentary lifestyle, like every one of us who is having more time at home. But there have been studies that have shown that people with neuromuscular disease have a higher risk of developing more or having a more progression during sedentary times and developing secondary disorders that are associated with the sedentary lifestyle, like obesity or diabetes. So then we need to really look at a program to get you moving, because any kind of movement is good if we can find a safe way for you to do it. One of the big reasons that sedentary time during COVID affects the muscles so much is that if muscles aren't used, the body basically thinks, well, they're not being used, so I'm not going to put energy into maintaining them. So the body starts to break them down, which decreases their size and their strength. That's called disuse atrophy. So that's part of the reason that we kind of push to move in some way, whatever's safe for your body. And then I would go back to finding a therapist that can help you develop a program to get moving, even if it's within your home, to keep your muscles moving.
Great, thank you. So to Dr. Kamdar, someone asked, I had a mitral clip procedure that appears to not have been productive. Might have this been because of my LGMD?
That's an excellent question. So, certainly heart involvement can be related to the limb-girdle muscular dystrophy. However, there's other non-limb-girdle muscular dystrophy types of heart involvement that can occur in other patients who do not have who are not living with limb-girdle muscular dystrophy. So in that case, in the case of this individual patient with the mitral clip, it's unclear what the specific cause of the failure was for the mitral clip. Typically, mitral clip is used when there's mitral regurgitation, so leaking of one of the valves on the left side. It doesn't always occur just due to the limb-girdle muscular dystrophy. So that's an important thing for patients as well as families who are living with limb-girdle muscular dystrophies to know that there's some part of the heart involvement that can occur from limb-girdle muscular dystrophy, but all the other cardiovascular impacts, high blood pressure, high cholesterol, diabetes, smoking, family history of heart disease are all important to take into account when you have symptoms, because your cardiologist should evaluate for possibilities that it's related to limb-girdle muscular dystrophy, but also exclude any other sorts of heart involvement that could be occurring from other causes that aren't related to limb-girdle muscular dystrophy.
Great, thank you. So to Dr. Kang, a question from the chat. Do you recommend taking anabolic medication like steroids or prednisolone for 2I/R9? If so, which would be the best one?
This is a tricky subject. As I think a lot of people know, steroids are pretty much, corticosteroids are standard of care in Duchenne muscular dystrophy. And now there are 3 different available forms of either corticosteroids or dissociative steroids. The picture is murkier for LGMD. There are some patients who have benefited from steroids. It seems like the benefit is a little bit less uniform and sometimes tricky to sort out. So there have been recent studies suggesting that there might be some benefit of taking corticosteroids in limb-girdle muscular dystrophy. But I think this is not, as far as I'm aware, a standard of care at this point. So I'd say have a conversation with your physician about this and discuss the pros and cons. There are a lot of side effects to taking corticosteroids. They can impact your weight and your metabolism and your bone health. And so it is something that should be a careful decision. I'd say it's worth thinking about, but yes, it's unfortunately a little bit murky right now.
That makes sense. And another question for you, Dr. King. We have quite a few questions for you in the chat, so I want to get to a few extra. A few people have been saying they've been diagnosed with LGMD based on phenotype, but there's no clear genetic result, or they're not really sure of their exact type. So how common is it to not be able to identify which type of LGMD you have, and how common is that, and is it important to know what type of LGMD you have?
One thing I do want to explain, I think most people in the audience probably know what the term phenotype means, but just to clarify that just means clinical features. So I saw the word phenotype in the chat, and so I just want to make sure that was clear. So unfortunately, it's more common than a lot of people recognize that you have a clinical diagnosis of LGMD, but there's some kind of limitation to your genetic diagnosis. Some people unfortunately have no genetic findings at all when they get tested, and other people have a potential diagnosis, but it's unconfirmed and a little bit ambiguous. And so don't feel alone, because there are other people in the same situation. And this is a particular specialty of mine in terms of research. And so we are doing genetic research into trying to figure out why there are these undiagnosed cases. So for anybody who has a confirmed clinical diagnosis of LGMD and is stuck with respect to genetic confirmation, you're welcome to reach out to me and I can connect you to our team. And so there are multiple explanations. One of the simplest, especially if you've been diagnosed a while ago, is that you may have had a genetic test that only had 10 or 15 genes on it, and now there are over 30 recognized for LGMD. And so if you had a genetic test panel done 10 years ago, it might not have had the gene on it that involves you. So it's worth going back to your physician, asking if the test is current enough and whether it's worth repeating it. Also, as much as we'd like clinical genetic tests to be perfect, sometimes there are either ambiguities or things that don't get picked up on an individual test. So sometimes people need multiple tests to get their final diagnosis. And sometimes that comes about as a result of just repeated clinical testing, but sometimes research studies can help, which again is what our team can help with. It is helpful to get a genetic diagnosis because it does impact your eligibility for clinical trials if you're interested in clinical trials. And also because a lot of the new therapies being approved, and I am optimistic that there'll be new therapies for LGMD approved in the near future, is that the eligibility to get medications even after approval may require a confirmed genetic diagnosis. So one other point I do want to make about some of the ambiguities. Sometimes some of you may be familiar with this term variant of unknown significance, or VUS. What we found is that another thing that happens is if you've had your genetic testing done years and years ago, a change in your DNA may have been marked as a VUS. But if you look up the same change today, you might find that it's either been reclassified as disease-causing or pathogenic or benign. And so the interpretations do change. And so that's another thing. If you have some ambiguities on your genetic testing, it's worth talking to your physician and seeing, is it worth just looking it up online and seeing if the interpretation changes. So I think it's really important for as many patients as possible to get their definitive diagnosis. So that is an important question.
Yeah, great. Thank you so much. And Dr. Kang, we do have quite a few people in the chat who are interested in the website you've been referencing for therapy and trials. If you have a moment, could you type that into the chat for folks so they can use that link? Thank you. So for Molly, in your webinar video, the advice is that your muscle should feel okay after about an hour of exercise. However, I can't follow that advice because my muscles are always tired. What exercise suggestions do you have for people with LGMD whose muscles are always tight and tired?
Yeah, that's a good question. When you're at baseline, I always have the red flags that I'm talking about with pain. So one is, I would say, if you have any increase in fatigue or increase in pain that's lasting more than 24 hours, then you know you've overdone whatever it was. But with all that pain and fatigue, I know it's very hard to do exercise. So then we got to think about, all right, how can we scale back, but you can still use your muscles, still activate them throughout the day, but not push them to cause any more discomfort. So one thing you can do that I think I touched on briefly in the presentation, but probably not enough for your case, is doing isometrics. Isometrics is when your muscle contracts, but your limb doesn't move to show the movement. It just tightens in place. So that's like squeezing your butt muscles or clenching your fists. or squeezing your thigh without moving anything else. And that's where you hold the muscle or hold that contraction for like 5 seconds, maybe 10 seconds, and then let it relax. And that tells the muscle, all right, turn on, contract, do your job, but then relax. You don't have to push it where you're moving the limb against gravity. So that'd be one area I would think about. The other thing is to really develop like a stretching program that either has somebody helping you or you doing it on your own. Because sometimes your muscles can get sore just from being in the same position for a long period of time. So having them moved, even if it's not you moving them, can be really helpful for managing that discomfort from that. And then if you do choose to do any kind of exercise that you want to push a little bit more, whatever you do, I'd have focused really on function. Like, and function, I mean, what do you need to do throughout the day to get your daily activities, your work, whatever it is, done? I don't know if this person is ambulatory or not. If they are, doing like sit to stands or marching in place or just standing is helpful to help with your transitions throughout the house. If not, doing some like seated reaching out to the side, reaching back and forth can help, because that's what you need to do if you're like brushing your hair or getting your meals ready. But the repetition of doing things a few times in a row is good to teach your muscles kind of the correct way to do it to support your body. And then finally, I would say consult with a PT if you haven't yet to make sure your program is really specific to you, because some of those things I mentioned probably won't be helpful for you and some might be and helpful for other people. So work with a therapist to develop your program and then get discharged. Do it on your own for a little while and see how you feel.
Great, thank you. I think that was really helpful. So back to Dr. Kamdar, how will LGMD affect my heart long term?
These are great questions. Not every patient with limb-girdle muscular dystrophy who's living with limb-girdle muscular dystrophy will necessarily develop heart complications. However, because we know that some patients do develop it, it's important to have regular cardiovascular screening. And this is why at the time of diagnosis, even in some of the subtypes of limb-girdle muscular dystrophy where the historical literature suggests that there isn't heart involvement, it's still important to have regular evaluation, because as Dr. Kang also mentioned, the cardiovascular and pulmonary health also impacts the overall trajectory for patients who are living with limb-girdle muscular dystrophy. So, even if you don't have symptoms, so many patients come to me and I ask them a lot of questions and they say no, and that's okay. So it's not a waste of your time or waste of your cardiologist's time. If a lot of those questions are no, the screening and being able to see heart muscle and heart rhythm and heart conduction system changes is really important. And the important aspect is being able to identify if those changes occur early on, because there are ways to be able to treat the heart involvement in limb-girdle muscular dystrophies.
Great, thank you so much. So back to Dr. Kang. Just a couple more specific questions from the chat. Could LGMD2N-R14 be amenable to treatment with ribitol BPP 418?
So ribitol has been studied pretty extensively for FKRP, which is linked to LGMD2I. The FKRP, the enzyme, is part of a complex of other proteins that help put sugars on proteins important for muscle function. So it is possible that there might be some benefit, but I don't think it's been studied. So I think that's something that first will have to be studied more in the lab before it's tried in humans. So I guess my answer would be possibly, but I think we'll have to look into it a lot more.
Thank you. And another question for you, Dr. Kang. I have LGMD type 2A. Can I expect to need a wheelchair at some point? Is it possible I could remain walking?
Everybody's trajectory does differ, and so there is a high risk of losing ambulation with type 2A, but the exact timing differs a lot. So I think if you are having a lot of increased difficulty walking, you are at higher risk. So what I generally do with patients in my own clinic is I try to watch what their trajectory is over at least a year or two before I start making predictions about what might happen when in the future. So it's a little hard to say, but it is a high risk situation. So I recommend close monitoring.
Great, thank you so much. So back to Dr. Stark, to Molly. What are the best home exercises I can do realistically if I only have energy for 10 to 15 minutes of exercise a day?
This is a good question. It might sound a little bit like my last answer because we talked a little bit about fatigue with that answer. So the main thing I think about is function, like what's going to really help you get done what you want to get done. Think about your goals and what could be helpful. Think about what you could do to integrate your activity into what you are doing. So for example, if you like to be on the couch or in your chair, I'm not sure, at night and watch TV, perhaps there's exercises you could do while you're sitting, like with a TheraBand or just moving your limbs against gravity, but to do them while you're watching something else, to kind of take advantage of your time. And then you can also have big rest breaks between it where you're watching something else, letting your body kind of totally rest before you do another exercise. And then my advice, I'm going to sound like a broken record, but talk to a PT so that you're developing exercises that you really want that are specific to you, so that you're not wasting your time and energy on ones that might not be helpful, that might be helpful for a peer of yours, but not for you.
Great, thank you. So back to Dr. Kamdar. Are there cardiologists who understand the heart activity of people with LGMD? How can I get connected with a cardiologist?
Again, great question. So it's really important to see a cardiologist when you're living with limb-girdle muscular dystrophy. So many, MDA centers, typically the neurologist that you're seeing will likely be able to recommend a cardiologist to you whom they work with. And you can certainly use the MDA website to look at the MDA centers that are available. But even regular cardiologists in the community, if you let them know that you have limb-girdle muscular dystrophy, they can certainly look it up. There's, I would say, still the MDA associated cardiologist is probably the one who will work with your care team, including your neuromuscular neurologist, your lung team, as well as the physical therapist, to come up with the best plan.
Thank you so much. All right. For Dr. Kang, what is the current status of research on methyl? There's a long name that I don't know how to pronounce for that, but do you know what methyl mevalonolactone?
Mevalonolactone?
Yes. And stage 1 or 2 testing on humans.
So that's a really interesting question because we're actually studying that compound in my laboratory. There was a paper published about a year ago on a new form of muscular dystrophy caused by mutations in this gene HMGCR. And there is a single report that came out and then a larger report with more families. I was involved with that second report with more families. And so that's an area of active investigation for my laboratory. The first report that had the single patient did study mevalonolactone. I think it's very interesting because this is all part of the cholesterol synthesis pathway, and we're hoping that we can find ways that could be therapeutic either for that form of muscular dystrophy or maybe even other forms. So it is an active area of investigation. I don't know yet if it can be generalizable beyond that specific type of muscular dystrophy, though. I think hopefully we'll find more answers to that in the coming years. But that is something that I personally am very interested in.
Great, thank you. So back to Molly, we had a question in the chat about water exercise. Do you have any feelings about that and any ideas of what a person could do if they have access to a pool to exercise?
Yes, I think aquatic therapy is really beneficial, or exercise in the pool. For LGMD, for people who are ambulatory and non-ambulatory. Exercise in the pool is great because if you can find a pool that's warm, meaning like 85 to 95 degrees, that can help your muscles kind of be more relaxed as you're exercising versus a cooler pool makes them all kind of tight and makes it a little bit harder to move. Water is great because it provides resistance. So you can do some strengthening in the pool. It's also great because it takes away the effects of gravity, so you can move more freely through it, through your whole range of motion for your joint. You can do endurance training in the pool by walking or swimming in the water. The warmth is good because you can stretch your muscles, especially after you get out of the pool. And then that low impact where it's taking away gravity is also good for your joints because you're not putting quite so much pressure through them. So if you're starting to develop a program, I would see a therapist who specializes in aquatic therapy. They don't have to know as much about limb girdle. It'd be nice for them, like I said earlier, to learn a little bit. But really, they can kind of go through and show you the ways you can move your body in the water to do exercises for strengthening, for aerobic, and for stretching. The main thing I would include when you're doing aquatic therapy is a warm up and a cool down because your muscle and your heart muscles, your skeletal muscles and your heart both need to slowly work into exercise and slowly come out of it. And then I would also say that aquatic therapy can be exhausting because it takes a lot of effort to get to the pool, especially if somebody's non-ambulatory, getting in and out of it, or like getting in and out of your home to get there, and actually being there in and out of the pool takes a lot of energy. So it's not something you need to do every day. Most people I know do it 1 or 2 days a week. And then once you're in the pool, spend a little bit more time. It's not a fast exercise once you do it in there, but make sure you're taking time for breaks too.
Great, thank you so much. So I just want to mention, we are running up here on about an hour. I do have a few more questions that are more general LGMD questions, primarily for Dr. Kang, but of course, Dr. Kamdar and Dr. Stark, if you have anything to add to these, please do. Dr. Kang did share his team's research, his research team's contact information in the chat. So if you want to reach Dr. Kang and his team, you can do so at neurogenetics@umn.edu. Just wanted to mention that. So I have been keeping up with the chat and trying to get to all of our questions. If I have not gotten to your question yet, and that's something that hasn't been touched on, you really want to make sure your question's answered, please go ahead and submit that again so that we're able to see it. So another question here for you, Dr. Kang, and perhaps Dr. Kamdar has something to say about this as well. What machine device medicine is recommended for LGMD and respiratory failure?
That was what machine or device?
It might be a bit of a typo. What machine device?
Oh, okay, I got it.
Machines, devices, or medicines are recommended for
Yeah,
LGMD?
I think both Dr. Kamdar and I can probably answer that. I'll say that options for respiratory support are much more varied than they were in the past. There's a lot of non-invasive options for support, like BiPAP, for example, nasal cannula. So I think it's important to monitor your respiratory health because there are a lot more options that are more comfortable for dealing with any complications that come up. So, and I'll let Dr. Kamdar add it to anything she'd like.
I think this is where seeing the pulmonary specialist is important. And then also having cardiovascular involvement, evaluating for cardiovascular involvement, because that can often affect the type of respiratory support you get. And because they're so interrelated, it's important. So.
Great, thank you. A quick follow-up to our question, Molly, about swimming. When swimming, I have problems that I come lying to horizontal. I cannot have my head above water anymore to breathe. Do you have any solutions for that?
I like the person's suggestion about the noodle. I also, it depends on what's causing it to be difficult to be up. If it's more contractures, keeping the hips and everything in a different alignment, or if it's weakness. But either way, there are some flotation devices that you can use to support your head while you're laying in the water. So I would support it so that you can, with something flotation-like, so you can focus on the rest of your body and not worry about what you're doing with your neck at that time.
Great, thank you. We also had a question in the chat. How does the panel feel about the possible use of an exoskeleton device to assist a person with LGMD?
I can talk about it a little bit from a therapy perspective. As a preface, I am not familiar. I don't work with exoskeleton devices. I've seen them before for spinal cord injuries. From my limited knowledge, I think you have to have pretty good trunk control because it's really just helping assist with like your leg movements. So if you have good trunk control and are looking for your leg, it potentially could work. I also think that it has a hard time with some people who have contractures that are more significant. So I think if you have limited contractures or none, it could be helpful. But in general, the best thing that you can do is weight bear through your legs. So even if that's in a standing frame or a standing wheelchair, in my mind, that's kind of the number one thing. And then the exoskeleton could be used for function. But like I said, my experience with them is so limited. I don't know how functional they are.
Does anyone else have thoughts on exoskeletons?
I know that there's been some development of exoskeleton devices for Duchenne muscular dystrophy, but those can be used for any neuromuscular disorder potentially. So I think the technology will keep getting better. I think one of the issues with it in the past has been that it's very bulky, but I think it's the materials are getting better, the controls are getting better, and now there's developments just in general about being able to connect to your brain and being able to control things more naturally with your brain. So that may become more of an option in the future. But yeah, I've not studied it extensively, but I think that's an important development that some patients might find helpful.
Great, thank you. So just so we know, it is about time to round up. I do have a few more questions I would like to get to, especially since we started late. But if any of our panelists do need to go, I want to be respectful of your time, and you are free to go. If you're able to stay and answer a few more questions, it would be greatly appreciated. So we had another question I thought in the chat that I thought was pretty interesting, and let me see if I can find it. So there are 4 girls in our family that have muscular dystrophy, and one got the test for the diagnosis. Would that diagnosis be the same for all of us?
I can answer that. I think if the symptoms are very similar and the other clinical features are very similar, in the past when genetic testing was very expensive and it wasn't always possible to test all family members, a lot of times we would make the assumption that they all do. I think these days, even if we think it's highly likely that everybody in the family who's affected has the same diagnosis, it's always nice to get confirmation with genetic testing. It is a little bit more accessible, both logistically and financially than before. But unfortunately, there are still people who don't have great access to genetic testing, so I don't want to assume that you can easily get everyone tested. But if that is an option, I think it's helpful to just get confirmation to know for sure.
Great, thank you. So another question probably to you, Dr. Kang. Is it true that during the teenage years, the progression of LGMD2A can slow down? My 14-year-old is experiencing very slow progression, but I'm concerned this may accelerate when he reaches adulthood.
So one of the reasons why I try to be careful about giving prognoses is that I've discovered over the years that the progression of muscular dystrophy, it's not uniform. It's not that a certain person changes in a certain way every year, year after year. So some patients may go through long periods where they're fairly stable and then suddenly something changes, sometimes without any known trigger. So the progression is a little bit, it's not quite as linear as I think people thought it was in the past. So I'm glad that that this patient is going through a steady period. I hope it lasts for a while. The other thing that I've noticed is that puberty can have very different effects on different people. Sometimes it's positive, sometimes it's negative. And so I think, yeah, because of all these reasons, it's a little hard to say what will happen in adulthood. But I'm glad that he is going through a steady period right now, and I hope it lasts a while.
Great, thank you. I do want to address a few things that MDA can help with as far as questions go in the chat. There were some questions about support groups, and MDA does have support group resources. So hopefully my colleague can put those in the chat for you. But if not, check out mda.org or reach out to our resource center, and they can connect you with a support group. And we also had a question about nutrition. I do want to let everybody know that we do have a Nutrition for Neuromuscular Disease print material coming out very, very soon. And we're also, we either recently had or about to have a nutrition webinar. So if you have any questions about nutrition for neuromuscular disease, we are going to be addressing that on demand here soon. So I hope that that will be helpful. So we had just a few more questions. I want to make sure to get to this one. How can I find information on other patient progression on rare LGMD subtypes like 1C?
So I can provide a little bit more information on that. So the MDA is, of course, a really good resource, particularly the MDA care centers, and those are listed on the MDA's website. There are fortunately other organizations that support specific subtypes of LGMD. And one nice thing about the MDA is that it's such a welcoming environment for other organizations as well. So there is a news magazine called LGMD News, which is published by the Speak Foundation, and they are an organization that tries to help all patients with LGMD. So especially if you have a rare subtype and you don't find an organization that may be covering that subtype, you can contact either the MDA or them, and both organizations should be able to help direct you and provide some guidance.
Great, thank you. We did have a question, if there are any updates, and this is to you, Dr. Kang, any updates with the JAG2 gene?
That's another area that my lab is actively studying. So we think we found, at least in a laboratory setting, a therapy that potentially could be helpful, but it's really been tested only in cells at this point, so it's very early. And so we'll be looking into that a little bit more. So please stay tuned. We'll try to keep working on it as hard as we can.
Great, thank you. So I believe this is for you, Dr. Kang, but Dr. Kamdar, if you have any thoughts on it, I'm not sure. What do you think about posterior tibial nerve stimulation to treat an overactive bladder for people with LGMD?
That I think I would refer to other specialists for that specific question. So yeah, I'm sorry I don't have a specific answer, but I think if you're going to any specialist who's aware of your primary diagnosis, that's in your local MDA care center or with your other healthcare providers, and make sure they have context before they recommend the therapy. But I think it's worth looking into potential therapies that are recommended, and just make sure that they're okay for your subtype.
Great, thank you. We had someone ask in the chat about adaptive aids. I believe if you're asking about equipment or assistive technology, we did just do a learning series about that, and there will be a print material as well. So please check out mda.org. The community education section will have information on adaptive technology and equipment for you. Our last question that we're going to take today, and I do apologize if anyone did not get their question answered. We did try to get to everything, but we do need to wrap up here. If you have any other questions, please reach out to our resource center. That's resource center at mda.org. And we also have a phone number I'll give you at the end of today's webinar. We would be happy to assist you and connect you with the resources you need to answer all of your questions. Thank you so much. So our very last question, is there any research in progress for mutations related to the desmin protein?
That's also a tricky one. I think the tricky ones came towards the end. The desmin is a protein that's being studied in a number of laboratories, and it's important to look for new therapies. I would have to get back to you about specifics on what's going on with that particular one, unless one of the other panelists has more information.
Well, thank you so much to all three of you for taking the time to stay with our community this hour and answer questions. It is greatly appreciated. I think if you see in the chat, we've gotten a lot of wonderful feedback. So we do appreciate your time and your support of the MDA community. And thank you all so much for being here today.
Many thanks to the MDA.
We are happy to be here. So I have just a few more things to share with you all as we're closing out here. If you are new to MDA and have recently been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who has been diagnosed, we encourage you to stay engaged with us here at MDA. You can do so by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. MDA's community education team would like to invite you to our upcoming in-person and virtual events. We are always adding more opportunities to learn with us, so use the QR code on the screen or check in the description box below to get involved with the MDA community. If you're watching from the future, not to worry, all of our virtual learning programs are available for on-demand viewing, and live education opportunities are updated regularly at mda.org. You can learn more about these events by visiting our website. We would love to hear your questions and comments about today's webinar. Please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1 or email the Resource Center at resourcecenter@mdausa.org, and we'll be sure to get back to you. Especially with these Q&As, we're not able to get to every single question that was asked in the chat or in the registration, but we do want to make sure we're connecting you with the resources that you need. So please make sure to reach out to us and we would be happy to connect you. I would like to thank all of our panelists today, Dr. Kang, Dr. Stark, and Dr. Kamdar, for their time and for sharing their expertise with us. This will conclude today's Q&A session. Thank you for attending, and we hope to see you again soon.